I'll get on that.
Okay, hey, thank you so much, bro. You rock, bro.
No problem.
Okay, take care, man. Bye-bye.
Bye. I'm watching live your drive scenario scene, and I'm listening to it. So I just want to.
Alright, so he's probably our sole listener.
Oh, there's lots of people
My
watching.
uncle. He's awesome.
Hello.
Hey, Uncle. Hey, how are you?
I'm watching you live.
Yeah, we're making progress, but we're about an hour behind the schedule right now. So, but it's going well. It's going well. So otherwise,
Yeah, the weather is kind of bad in this part of the world.
Yeah, we had some rough, but finally we're picking up some speed now. But everything's kind of off by about 1 hour. So you'll definitely be there tomorrow morning, right, Uncle?
Yeah, I'll be there.
Okay, cool. So.
In fact, JD's wife, myself, and Angie.
Oh, cool. Awesome.
Yeah, so we are planning those. All three of us are planning.
Awesome. Hey, thank you so much, Uncle. I really appreciate it, and we'll.
Absolutely.
This
absolutely.
is.
I
It's
know
so.
there's a whole bunch of people will be there.
Yeah, there's a whole.
I already spoke to Daddy earlier.
Okay. Cool.
Yeah, I spoke to Daddy yesterday also.
Okay, awesome.
Yesterday.
Yeah, so this.
I know you were busy. That's why I didn't call you.
Yeah, it's been crazy, but this is it's amazing. It's so cool. We had like 200-300 people in Claremont when we took off. It was amazing.
No, I saw the ribbon cutting ceremony.
Yep.
The ribbon pulling ceremony. The ribbon cutting thing, and I was watching. I was following you guys.
Awesome. Yeah. Well, thank you so much.
And yeah. Hopefully, are you taking the Lincoln Tunnel or the Holland Tunnel?
Lincoln Tunnel.
Lincoln Tunnel. Okay.
Yeah. So hopefully.
You're right there. I know that area very well.
Yeah.
I used to go to St. Vincent's on 14th.
Yeah.
Hey, Wade. Hey, I just sent you a link, man. Come join us.
Hopefully we'll get through. So, all right, Uncle.
Okay.
We're gonna start our webcast right now, I just wanted to call you and let you know where we were, and we're in North Carolina right now. So. Okay.
Yeah, I'll be watching you.
Okay. Thanks, Uncle. Okay. Bye.
Bye. Stay safe.
Okay. Bye. Wait is on. Sorry.
Dude, seriously, man. I mean, it can wait.
Hey.
So, what is the speed limit here, guys? Do you guys see anything?
65.
65.
Hey, Jamin.
Yeah, what's up, man?
Hey, somebody requested on Facebook that they would like to see you guys wearing rubber gloves when you drove.
Okay, you want to see rubber gloves when we drove? We would love to do that, but we don't have any rubber gloves. But for next year, as we go into LA, we will wear Michael Jackson white gloves.
That's awesome.
Yeah, I thought it was a funny comment. Maybe you guys shout out to Wayne Haskins. You know him?
Who?
Wayne Haskins.
Wayne Haskins. Yeah, shout out, bro. Shout out.
Okay, no problem. We'll do a shout out to him.
We need Wayne. Wayne, he's the guy that gets the paper guy.
Oh, he's the paper guy. Oh, that's right. Okay, we'll do a shout out to him.
The Southwest Bulletin.
Are we broadcasting live?
Yeah.
Okay. So you did the shout out, right?
Yeah.
So, all right, shout out for Wayne Haskins.
Wayne, thank you so much. You've helped us so much publicize this event. Thank you.
Really appreciate it. Thank you so much. So you got Wayne section.
It's going to be perfect because I'm going to have Wade, and then we're going to have Dr. Brian start talking about, because he's going to talk about bladder cancer.
Awesome.
So I'm going to get all of them on the same call.
Perfect. That is awesome.
Guys, we're really sorry. We're running an hour behind. To all of our presenters, they've been so patient with us. And thank you guys so much. We're just waiting for Dr. Sexton to log on. At this point in time, we would like to once again thank all of our sponsors. You know, we are reaching the second half of our marathon here, and this is when, you know, it's the hardest. We are so freaking tired. It is. I mean, I think mentally we're still strong, but physically, you know, we're hurting. Hey, Wade, how you doing, buddy?
Hey, Jamin, how are you?
Good, good, good. Hey, thank you so much. We are here driving. We just left Santee, and we're headed to Rocky Mount. Yes, I do. Will it waste electricity?
Where are you?
We are now headed to. We're driving up to Rocky Mount. But thank you so much, Dr. Saxton, for joining us. Dr. Saxton is at the Moffitt Cancer Center in Tampa. He is actually an expert in his field, and I'm going to let him give us a talk today about bladder cancer. Is that correct?
Yeah, you got it.
Hey, thanks so much, Wade. Really appreciate you taking the time.
And everyone that's watching this, you're not going to be able to see us too well because it's dark outside and we don't have great lighting here. But Wade, you look bright and fresh.
Well, good. I don't feel so fresh. I've been operating on bladder cancer all day. Hey, listen, we'll talk just a few minutes and then let you guys ask some questions. Hey, C-Joe. You guys be safe, by the way. Well, you know, what we'll do is just cover a little bit for the next 5 minutes or so and open it up to you guys for questions. And you fellows know that bladder cancer, of course, is one of the leading causes of cancer, I think, that men experience. The fourth most common cancer that we treat, and a very important cause of cancer-related death. Eighth most common cancer-related death. And you know, what amazes me about that is when you see patients who come into the clinic, they don't realize the impact that bladder cancer has on men in this country. You know, the other thing is the fact that bladder cancer is the most costly tumor that we treat and manage, and there are multiple reasons for that. The treatments, the diagnosis, the need for what we call surveillance, so looks into the bladder periodically, etc. But many men and women, for that matter, but men don't talk about bladder cancer much, in part because it's something that I think is very private. We don't see politicians talk about bladder cancer. We don't see the Hollywood types talk about it very much. So there's not much attention given to bladder cancer by and large, and I think you guys would agree to that. For the men who may be listening, there are some different risk factors for bladder cancer, to include smoking. That's the most common risk factor we see. And you know, it's amazing the number of men who come in and you're talking to them about bladder cancer, or they have friends that have bladder cancer, and they continue to smoke. But it's smoking and secondhand smoke exposure. There are industrial exposures, arsenic in drinking water, some other risk factors, etc. But by and large, that is something, a modifiable risk factor that I think that men need to be aware of. Smoking-related illness and bladder cancer is one of those. Men should also know that there are common symptoms, and those symptoms include blood in the urine. That's gross blood in the urine that a man might see. That's a problem, and that should seek immediate attention by a physician to discuss that with that particular man and work that up. Men may also have microscopic blood in their urine that they can't see. And that's why it's important to have routine evaluations by their primary care physicians, who are the gatekeepers to medical care for that matter. And if there is microscopic blood in the urine, that would warrant a referral to urologists. Some men may have what we call irritative lower urinary tract symptoms, where there's a lot of frequency and urgency and burning with urination. Now, there can be some non-cancerous reasons for that as well. Or men may have some difficulty urinating due to what we would call obstructive symptomatology. Now, I bet somewhere along the course of the day, you guys have had a conversation with men who've talked about BPH, benign enlargement of the prostate, and the symptoms that might cause. So, but something else to keep in mind. Now, when you look at men with bladder cancer and women, about 75% of men will present with bladder cancer, and it's not grown deep into the bladder wall. That's called non-muscle invasive bladder cancer. And fortunately, that's still a very curable type of cancer, but it's a type of cancer that can become worse. More importantly, it's a type of cancer that can recur. So there are other types of cancer that we see in the bladder as well. While 75% or so have bladder tumors that aren't very deeply invasive into the bladder, another 25% will have tumor that's grown deeper into the bladder called the bladder muscle. And finally, unfortunately, only about 5% of men will have bladder cancer that has metastasized or spread to another part of the body, which makes it very difficult to cure. Now, when we see someone with bladder cancer, there are various procedures that urologists are going to do. We're going to look in the bladder in the clinic through a small scope that's like a small catheter. It's very atraumatic. It doesn't cause much pain or discomfort, but it is the best way to identify a tumor, and essentially the gold standard for us to look and evaluate the bladder in general. Other types of issues, if we see tumors or red areas in the bladder that might be concerning for bladder cancer, then we're going to take that patient likely to the operating room to do some bladder biopsies or to remove that bladder tumor, and then based on how deep that tumor goes into the bladder wall, the number of tumors, the size of those tumors, etc., will dictate how we're going to treat that patient. So there are many treatment options, and in part that's what causes the significant cost associated with bladder cancer. But some of those treatment options include, if it's a very superficial or non-invasive tumor, those options may include not only removing the tumor, but putting medicine into the bladder to try to prevent a tumor recurrence, or putting a medication into the bladder to try to prevent it from growing deeper. If those types of treatments don't work, then there are times when we're going to need to do something more extensive, and that might even include using a combination of chemotherapy and radiation therapy to try to treat some of the tumors that are deeper in the bladder. Now, the standard of care for men who end up having some of those tumors that grow deeper in the bladder is actually something called cystectomy or bladder removal. And that's in part, men just don't like to talk about these issues very much, because when we begin to remove the bladder, and usually we remove the prostate gland as well, then we have to create types of urinary diversion. We have to reroute the plumbing, so to speak. And there, briefly, are three ways to do that. One, we can reroute it to the out through the abdomen into an ostomy bag. Sometimes we can build a new bladder out of intestine and sew that back to the urethra that runs through the penis, or create a reservoir for the urine. It's called a continent catheterizable diversion, and we can teach men how to pass a catheter through the abdominal wall to prevent having to wear a bag. But there are multiple options we have in those circumstances, and of course there are many other factors we take into consideration when we're trying to decide how best to treat that man with either invasive or deeply seated bladder cancer or bladder tumors that aren't quite as deep. But suffice to say, this is an important cause of cancer in men. It's one of the top 10 causes of cancer-related death. It's a very costly cancer, and I think Jamin, you and Sijo and myself and many of our colleagues really believe that researchers and national providers of funds for bladder cancer research, that really needs to increase so we can better impact this disease that affects many men across the country.
That was great, Wayne. Thank you so much. You had mentioned you have to take the prostate out sometimes. Why can't you just leave the prostate in there?
Well, that's a good question, Jamin. And there are select people who have, and institutions who've looked at trying to spare the prostate gland. But in men, for instance, those that have bladder cancer, the urethra runs right through the prostate gland and can be a very common site of tumor, but could also be a common site of tumor recurrence, particularly in the high-grade setting. So removal of the prostate under most circumstances is standard of care and part of what we would consider to be a total cystectomy in men. But under select circumstances, it might be preserved, but the standard of care is to remove that, of course. You know, the other thing is, unfortunately, it's a disease of older ages as well, Jamin, as you well know. The median age of the patient, for instance, when we have to remove the bladder and prostate, the median age is somewhere around 68 to 70 years. Men still have concerns, of course, regarding potency and erectile function and such, and that's in part why I think it makes it a difficult decision and a topic for many men to discuss.
So one more question is, so how do you decide whether a patient gets a new bladder or whether, you know, they end up getting like an ostomy? Can you describe a little bit what an ostomy is? And the reason I ask you to describe it is because after you, we have Brian Storp, and we're also going to have Joseph Solis, who have created a device called Stoma Cloak, which helps decrease the scent from these ostomies. So if you could kind of lay the foundation for them, because that's a life-changing thing to have a bag on your belly like for a lifetime.
Oh, absolutely. You know, and that's again, men and people who are affected by bladder cancer don't talk about that much. I think it's important to know, well, first of all, in terms of who might require an ostomy, essentially we would take about a 12-centimeter segment of bowel, which is probably about 4 inches or so, 4 to 5 inches of bowel, and we would isolate that from the intestine, then put the small intestine back together. And then we would take the 2 ureters, which are the long tubes that drain the kidneys down to the bladder. When we remove the bladder, we divide those ureters at that level, and then we sew those ureters into the bottom end of that bowel segment, as you well know. And then we would bring the bowel up to the level of the skin. Now, there are various factors that would help us to determine, in addition to patient preference, for instance, but there are other factors that would help us to determine whether or not an ostomy was the only option for that patient versus a neobladder versus a continent catheterizable diversion. And we take into consideration patient age, medical comorbidities, the extent of their disease, their kidney function, the quality and the characteristics of their urethra, and whether or not there is tumor within the urethra, for instance, or whether or not there might be scar tissue in the urethra. Again, patient preference. There are many features, I think, that we have to consider, and many factors we have to consider.
Yeah.
But even if that patient requires an ostomy, they're not doomed to a lifetime of exclusion. They can swim, they can travel, they can lead, they can play golf, they can be quite active, they can still live. So that's important for a man to keep in mind. Yes, we do have other options in terms of urinary diversion. We can build a neobladder in certain circumstances and sew that back to the urethra and teach a man to urinate again through a bladder substitute. But men can still live and lead a high-quality life even if they have to have an ostomy.
Yeah. Well, Wade, this is very interesting. So, if there's something that you would like to tell all men out there, what would that be in regard to why they need to take better care of themselves?
That's a good question, Jamin. And before I answer that, I'll say congratulations to you and Sijo for your own drive to make men aware of multiple health issues. Sijo, I see you there, man. Be careful. Be safe. Thanks for the opportunity to participate tonight, and you guys are just to be commended for really thinking out of the box. But what I would tell men is, number one, if you're a smoker, okay, there is many reasons to quit, and bladder cancer is one of them. If you have children, secondhand smoke is a risk factor as well. And not only you taking your own life into your hands, but you're potentially taking the life of those you love into your hands by really failing to recognize the harms of tobacco use. The other thing that I would say to men is that, talk with these issues. If you ever see any blood in your urine, that's a problem, and that needs to be evaluated. And discuss these issues with your primary care physician as well. Routine health maintenance is key. Microscopic blood in the urine is an abnormality that we should see. You don't ever have to just see it. If we can see it microscopically, that's an indication for a workup, and maybe we could catch something earlier. So good luck to you guys. Thank you for allowing me to participate, and take care.
Thank you very much, Dr. Saxton. We appreciate it. We look forward to having you come drive with us next year when we go.
Yeah, okay.
But in all seriousness, once again, thank you so much. It has been a pleasure to have you on and talk to us, and hope you continue to follow us on our website. Thank you.
All right, Jamie, take care. Sijo, take care. Be safe.
Thank you so much, Wade. Appreciate it.
Bye-bye.
Brian, are you on?
Yeah, I'm here somewhere.
Nice. I can hear you. Hey, Brian, this is Dr. Saxton. He is an expert on bladder cancer. I think you guys have probably met. Brian, wait, Dr. Saxton, if you have a minute, Brian is a urologist in Michigan, and he's on the social media committee and the AUA with Stacy Loeb and staff. And him and his partner has devised a thing called Stoma Cloak, which it's a covering for the stoma to help decrease the stent. So we're going to be talking about that now, but I know you probably got to go, Wade, but thank you so much.
All right, take care, guys.
Thank you. All right, Brian.
Hey, how's it going?
It's going. Hey, Brian, we're really sorry running an hour behind. I know you have been waiting for us for a long time.
No, it's no worries, man. We made a video for you.
Yeah, so can you send me the link, and I will play it live right now while you are still on with us.
Oh, yeah.
If you email that link to me, we can basically play that video during this live broadcast. So,
hey, that would be great, because I seem to be technologically challenged tonight. I can't figure out how to get the video going, but it's a great picture.
How are you like social media guru at the AUA, and now you're having difficulty here, Brian? I just don't get it.
Whatever can go wrong will go wrong, you know?
No, but Brian, I am very intrigued with the device, and I mean, it's not a device; it's just a cover. And I think we've talked about it several times today. When we were driving up to Santee, we talked about it quite a bit as well, and how we got to get guys talking about health issues, but once they get the treatment, then they are left with these things, and how do we make their lives easy?
Yeah, so that's how we got started. You'll see in the video my partner.
But now they're left with the partner.
Oh, I'm sorry.
Yeah, just send me the link, and then we will. You send it to me?
Yeah, so I sent it to you. So you're right. Quality of life issues are important. That's how we got started. My partner, Dr. Salas, developed a real severe form of bladder cancer several years ago and underwent some really aggressive surgery, in which they took out his prostate, his bladder, and it's not a normal surgery for bladder cancer. I want to make that pretty clear. But given the situation he chose some very aggressive surgery. He had his bladder removed and he had an ostomy, and he was having some problems with his ostomy. He was having some perspiration on the bag. He was noticing an odor to the contents of the ostomy. So we live in a major manufacturing community, and we just all put our heads together and created this carbon-impregnated polyester cover for his ostomy device, and we call it Stoma Cloak, but it's just designed to make people's lives better.
Brian, can you hear me?
Yeah.
Okay, I'm going to go ahead. Whenever you're ready, I'm going to play the video.
Okay, go ahead.
Okay, hold on.
Hey, guys.
Brian.
Yeah.
Hey Brian, could you see the
Now.
video stuff, or did it come through on your end?
I didn't see the video. Can you guys see me now?
Yeah, I can see you, but we're supposed to.
Here with
We're supposed
Joe
to see
Sala?
the video, and it worked.
Yeah, Dr. Salas is on call tonight, so he had to go.
Okay.
No, that's okay, man. We're sorry about that. We're just trying to figure out the logistics here. This work's working earlier.
Your video is kind of cool, man. You guys look like you're in a space capsule or something. There we go.
We look forward to assisting anybody in need. Our company hasn't made any money, but
Oh. Hey, Brian. Brian, unmute yourself. Unmute yourself.
How's that?
Hey, Brian, that was great, man. Thank you so much. So if you had, I mean, I think it's a great thing. We've been talking about it all day, and thank you for your support for our drive. And I'm really sorry that we're keeping you late at work so you can interact with us. But Brian, if you had, something to tell men and yell at them about, what would that be when it comes to men's health?
Well, I think we're all guilty of the same things. I mean, we're all guilty of not exercising enough. We're all guilty of overeating. We're all guilty of not taking good enough care of ourselves. We're all guilty of not going to the doctor or taking our medicines the way we're supposed to be. And at some point, I think we just have to think about, our wives and our kids, especially with Father's Day coming up. We just have to think about ourselves and what role we're going to play in their future. And, we're limited in this universe by our bodies, and if we don't take care of our bodies, well, that's all we got. So I just encourage men to take good care of themselves, see their doctor, think about their health as a priority, and not just something in passing, Can you guys hear me?
Yeah, I can hear you. I can hear you.
You guys look like you're in outer space, man. It's pretty cool.
Well, we are, man. We're here in the Tesla. Here, hold on. Let me show you what we're doing.
He can show you.
Hold on. So it's dark now, but this is us. Fred, reveal yourself. Hey, Fred.
Hey.
Acres Media. He's following us.
Ryan, how are you?
Hey. Keep driving the road, man.
Don't look this way. Don't look this way.
I gotta look at the road.
No hangouts and driving.
Yeah. But it's a great car, Brian. Well, thank you so much, Brian. You've been very supportive of our drive. You've been tweeting and socializing about it since we talked about it, met at the AUA. We really appreciate your support. And next year, as you said in your speech, we will be getting an RV, and you will be following us because we are going to be. Do we drive through Michigan?
Yeah, we are the bottom part. So.
Yeah, because we're going to LA, so we'll definitely be. You can tag along either before or when we reach Michigan. But thank you.
We're the Motor City. You got to come through Michigan.
No, we will for sure. All right, Brian. Well, thank you so much for stopping by. I appreciate your time.
You guys have a good night and drive safe.
Thank you, Brian. Thank you very much.
Yep. Bye-bye.
Your call has been forwarded to an automatic voice message system. 813.
The other guy didn't pick up, right? Huh? I did message them, but I don't know where they are. I mean, it is like 10:17. So, but still. Guys, it's late. We appreciate. One of them is doing bedtime. Can I join later? 1 or 2 hours from now. I said, sure, let me know. We will. I think our last webcast ends at 12, so that is perfect. That is perfect. Well, I know we are affecting a lot of sleep schedules today, so sorry about that, guys. But we were supposed to be on about an hour ago with Dr. Lennox Hoyt. I don't know if he's going to be able to join us, but just wanted to let you know that he is also at, actually he's at USF, and he is
That is great. And the other person I was going to talk was Dr. Luca. Technically connecting, but he is a great guy. I know him from my medical school days, and
Something actually very interesting, and I don't know if you guys saw New York Times about a week or two ago had an article about men's health centers of excellence, where basically it's a one-stop shop. You go in, you get to see cardiologists, urologists, endocrinologists, skin cancer. Heck, you can even get Manscaped if you want. So it's basically like a one-stop shop where it's comfortable for men to go. And I know.
What we could do is we could probably try and get like some video vignettes from them.
Yeah.
And the idea is that this website and this event is really just the beginning of something that we'll carry on every year. And so what we're hoping to do is, people coming back and visiting the site, we're going to have new stuff on there all the time. And the goal is that we get more talks, and any of the talks that we may have missed due to technical issues, we can post and keep there as a permanent repertoire. So that way, it'll be a nice resource for guys to look over for specific topics.
Yep. Thank you, Sujo. All right, guys. So we haven't been able to reach Dr. Num, but Sujo, we have a message, and I'm going to read it out loud right now. Let me turn my light back on. So one message says, this one is, ready? This is Sujo.
Okay.
Fred, 5 tips for staying awake while driving at night. Fred, can I get a drum roll? Number 5. In car activities, shake your head from side to side while taking a deep breath. Okay, I feel like throwing up. Number 4, engage the senses. Lower the air temperature, which it already is freezing in here. Wipe your neck and face with a wet cloth. We have wet cloths, but they smell like beef. While eating sunflower seeds one at a time.
No, Dr. Mathis.
Where's he at? Oh!
Hey, Dr. Mathis.
Hey, how you doing? Where are you guys right now?
We are passing.
We're 45 minutes away.
Yeah, we're about 40 minutes away. We're the name of the town is. I can tell you in just a second. I'm just looking on the map. We've passed Benson a while ago, and we're coming close to Smithfield.
Okay.
And Selma is like the next small town, so we're kind of in that region. So the GPS is saying about 40 to 50 minutes. So it's probably going to be about 11 o'clock by the time we get there.
Weird thing is that place is Dr. Robertson, I can give our talks simultaneously. That way people could listen to both talks at one time and double their learning pleasure.
Sure.
Oh, that's fine. That's perfect.
No problem, because we're counting on you guys to run the show there.
Yeah, because we're going to be showering.
We're going to take a quick break to shower and freshen up.
So the show is yours.
So you guys can do whatever you want. And, the AV team should be there hopefully, and they're setting up the platform. So hopefully they should be there soon. Is there anyone there yet, or are you guys there already? Or
we're not there yet. We're driving over.
Oh, I see.
Yeah, we got a shower, man. Oh, so that's good. We don't feel that bad then.
Yeah. So yeah, if you're driving over, so when you get there, our AV team should be there already, getting everything set up and stuff. So yeah. By the time you get there, there'll be part of our crew there. And what happened with the Tesla, we have 5 Teslas, so when we charge them all at the same time, it slows down the charge for all the cars, so we staggered it. So right now there's about 1 or 2 Teslas there, and we're kind of staggering. So most of our team will be there before we get there. We're like the last car. And so that way we can charge fast by the time we get there. The next set we'll kind of stagger it into 2 groups so that the 2 cars can go ahead. So unfortunately, we hadn't planned for that. That's what led to this initial delay. But right now we're picking up some good speed and figured it out. But so we should be there by about 11:10 around that time frame. So I think.
Okay.
Yeah. All right. So thank you so much, Dr. Mathis, and sorry to drag you out so late, and I really appreciate you coming out. So, but you guys can do a combined talk, and pretty much the stage is yours, and we'll have like 2 microphones and 2 TVs. If you want, you can do slides, but you could just talk too. You know, it's more of a patient-centric thing, so it's probably better to just kind of go back and forth. And lost them. Hey, Dr. Mathis. Hello.
Yeah, I just let you know Dr. Mathis is on call, and he may or may not be available at the time. But I think things are, developing into hospitals. I will be there.
Okay.
Okay, no problem.
I'll be there for sure.
Okay, no problem, no problem.
Yeah. Okay, thanks.
Okay, no problem. All right, take care, guys. Okay, bye.
Hey, so guys, all right, we're about 40 minutes away from Rocky Mount, where I know they have been so patient with us. We are running about an hour behind, so you know, it is what it is. Yeah. This is crazy, man. This is crazy. Oh, we gotta do our top 10 list again after we get off all our phone calls. All right, so Joe. Second. Okay. So Joe's not paying attention.
Hey, what's up, man? Oh, yeah, we're pretty tired and about an hour behind. But,
it's Dr. Lee!
But we're doing well, man. No problem. So overall, doing well. Let me just put you on the speakerphone. Hello?
Good.
Hey, yeah. So unfortunately, we're about an hour behind, but we're doing good. We're over halfway through. We're just about to get to Rocky Mount in about 40 minutes or so, 40, 50 minutes.
You're about to get to where?
Rocky Mount, North Carolina. So,
good work, man.
Yeah, I know. Yeah, so we're over halfway, but this thing's awesome. It's a lot of fun. So you can watch us live, on the streaming on our website. It's driveformenshealth.com. So we've got a few talks and stuff, but it's going well. It's going well.
Good. Got out of the meeting in Vegas.
Oh yeah, that's right. How'd your meeting go?
Nice, as usual.
All right, guys, I'm gonna mute this because it's Dr. Lee talking. So. All right, guys. So listen, Joe. I'm getting freaking tired here, but listen.
So yeah, I knew that Mathis guy would be blocking this.
No.
Hey, Caden.
Hey, man.
It's Dr. Badani!
So,
Hey, guys.
you want to do your? Should we do stop now?
I think, yeah, you can log in. Come on, log in. We're gonna do top 5 reasons to stay awake, and then while we're waiting for you to log in, we will do that. So let me send you an invite. Are you at a place where you can do it now?
Yeah, I can do it.
What is your email address? Like badass New York City surgeon at Gmail or?
You want my email address?
No.
No, I got it.
He's just teasing.
Okay, I sent you a link. You log on. We're gonna be doing some stuff while you log on.
Unfortunately, Jabin's getting tired, so you can tell. So I'm just worried
All right.
about his condition at 6 in the morning.
All right, guys. So what we're gonna do now? So Ketan, get on, bro.
Hold on, I'm trying to log in. Okay, got it. All right, I'm coming.
Okay. Hey, it's my wife again. Hello.
Hi.
Hi, Julie. How you doing?
Good. How are you?
Okay. And then how do I get my talk on?
Let me call you guys later.
So once you log,
9
I'm
o'clock.
joining
We're
right
running
now.
1
yeah,
hour
once
behind.
you
9
join,
o'clock.
the small green button to the
Oh, there you go, sexy beast right here, dude. How many bottles of wine do you have in the back here?
I can see why. Yeah, dude. That's what I'm doing.
Hey, Ketan. Hey, man. We're gonna do this. Oh, where'd you go?
I'm here.
Okay. Hey, listen. We're gonna do this with you. We're gonna look at your reaction. So, we're gonna do the top 5 ways to stay awake in the car. Okay?
Should I turn him off here?
Yeah, turn them off here.
Yeah, can you hear us, Caitlin?
Yep, I'm going to turn the volume up here. Hold on. I'm a fancy new Mac Pro, so I'm just trying to figure it out.
Oh, Mac Pro, awesome.
Nice,
Dude,
nice.
you must have got a nice bonus in your place, man. All right, we're going to do top 5 ways to stay awake while driving at night. Number 5. Ready? Drum roll, please, Fred. Shake your head from side to side while taking a deep breath. Okay, that's making me nauseous.
That's mild at best.
Number 4, engage the senses. Lower the air temperature. It's already freezing in here. Wipe your neck and face with a wet cloth. We have wet cloths, but they smell really bad. And while eating sunflower seeds one at a time, we're watching our cholesterol, so no sunflower seeds. Number 3, drum roll, please. Open the window, but close it when your contacts begin to dry out. But we can't open the window because it affects the drag of this car and we get bad mileage. So we can't do any of this. Number 2, listen to music that you hate, but still try to sing along. Well, yeah, I hate all of Sijo's music selections.
What does he listen to?
Just kidding. And number one, why oh why did you not use prescription drugs? Well, thank you for that contribution. Yo, Ketan, how you doing, man?
I'm good. How are you?
Hey, we can't see you though. No, you were there. Actually, we can see you now. So, did you figure out how to do your talk?
I can't see you though.
Well, we're in the dark. That's the problem here.
Yeah, we don't.
Oh, that's good though. Okay.
Yeah, we're in the dark here, but we can see you, and I think we're pretty good to go.
All right. So how do I get my talk on here?
Okay, so on the left there, you have a green button that comes up when you hover over it, and it says screen share. And so you basically just screen share that. So just go ahead and screen share where you see your PowerPoint or whatever you're presenting through, Keynote, PowerPoint.
Oh,
Oh my God! Look at that! Look at those beautiful slides.
Got it. Oh man, Mount Sinai, nice.
There we go. I don't want to control accessibility. Okay. Okay, this works. Good stuff. You guys there?
Yeah, we're
nice,
here. We're here. We're
nice.
listening, man.
Nice colors, man. Nice colors. Go for it, man.
All right. So what I'm going to do is talk a little bit about robotic surgery and kidney cancer. And the reason why I want to talk about this is because it's obviously robotic surgery is mostly started off with prostate cancer, and it's still the most common operation performed. But kidney cancer is a close second in terms of robotic utilization, as you guys know. So I think it's an important topic, and thank you for letting me talk about this. So what I have here is, this is the NIH sort of top cancer list, and you can see in both men and women that kidney cancer is, in the top 6 or 7 for both men and women. So it's not an uncommon disease. So what we have here is a kidney, and on the left kidney, which is this one, you see a tumor. And this tumor is sort of the top third of the kidney. And the most typical operation that was done to treat this type of tumor is what we call a radical nephrectomy, so the whole kidney. And what we want to try to do is what we call a partial nephrectomy, which is just the tumor and a little bit of the extra stuff around the tumor so that you get what's called a clean margin, meaning you completely remove this tumor. But you still have a good 66–70% of the normal healthy kidney remaining. And this we know is good for long-term survival, for long-term kidney function. And so when it's feasible, you really want to try to do this. So the role of robotics in kidney surgery is the same as it is for minimally invasive, and I know you guys have talked a bit about this, but it offers a minimally invasive approach to this type of operation. And the other important thing is something called ischemia time. And ischemia time is when you have to temporarily clamp the kidney and stop the blood flow. The kidney is a blood filter, and so if you just cut into it to remove a tumor, you're going to get a lot of bleeding on your hands. So you actually have to stop the blood flow for a period of time and then cut the tumor out and sew it back together. So that time is important, and really you want to stay under 30 minutes. And that's sort of the goal. And what I'm going to show you is a technique that keeps us well under that 30-minute rule. And at the same time, we're kind of being safe and efficient in minimizing our complication risk. So we published this technique about 1.5 years ago called the FAST technique of robotic partial nephrectomy. I'm going to show you some examples of it in a little bit of a video. But essentially, I'm going to do some case examples first. So this is now we're looking at the right kidney as opposed to what is the left kidney. My Mac Pro here is a little too sensitive. Not used to it yet. So this is a small tumor, and it's a lateral tumor on the outside of the kidney. And this is a young guy, 36 years old. And so we did the FAST technique to remove that part of the kidney. And what we see here is that the ischemia time, right, the time that the kidney is without blood flow was 11 minutes, which is well under the 30-minute mark. And that's really what your goal should be for what is essentially a very small, confined, ended up being what's called a renal cell carcinoma, that's RCC, and negative margins, right? That's the goal. So this patient's cured of this small kidney tumor, despite him being young. It was found at a very early stage. Here's a 56-year-old patient of mine who I took care of very recently. And I'm going to point out the tumor right here on the right kidney. And you see it's a little bit more complex because it's deep inside the kidney. It's not sticking out like the other one was. So this makes it a little bit more challenging, but still our goal should be to do a partial nephrectomy. And so with her, we're able to do this, what we call endophytic tumor, in an ischemia time of about 18 minutes. So it took a little longer than the first one, but still well under the 30-minute mark for what is essentially a fairly, what we call mild to moderately complex tumor. And this was also renal cell carcinoma, and we achieved what we wanted to do. This is a nice lady, 75 years old, who came to me who wanted to have her kidney preserved and was told that that wouldn't be possible. And what you see here is what I would consider a very complex tumor. It's big, it's into what we call the hilum, so the main artery and the main vein, and it's also deep in the kidney. So it's got all the things that make it very challenging. But still, we're able to do a partial nephrectomy robotic, and with an ischemia time listed here of 21 minutes. So again, a little bit longer than the last two because of the complexity, but still in the safe range and in a very acceptable range. And this was renal cell carcinoma as well, a little bit larger at 4.2 centimeters. And this is the 5 holes we used to do the operation. And again, that's in contradistinction to the traditional open incision, which you see on the left, that goes kind of from the front to the back. We call this a flank incision. And we're doing it through these 4 or 5 holes you see on the right. The most unique and probably interesting new technology that we're using for kidney is something we call immunofluorescence. Immunofluorescence allows us to transilluminate arterial blood flow. So we actually inject a dye into the patient. It's safe dye. And it shows you the arteries that feed the various parts of the kidney. And you can see that in green on the right. And what you want to do in settings where it's possible, it's not always possible, is to find the single part of the artery that actually just feeds the tumor so that you can maintain blood flow to the rest of the kidney, meaning you don't have any ischemia time to the parts of the kidney that you're not worried about. So this short video, can you guys see the video? This short video shows you a tumor at the bottom of the kidney. You see that here. And I'm just marking out the margins because we want to get margins. And we have this Tile Pro, which is a picture-in-picture view of the ultrasound in the tumor. I'm putting in all of my stitches, everything I'm going to need to use ahead of time before we clamp the kidney, because we want to save on these extra steps, right? You want to save on time. So part of the FAST technique is to set all of this up in the body. I'm going to put a clamp, temporary clamp on the artery, and this is what I think is just the artery that feeds the lower part of the kidney. So the clamp is on, we go into immunofluorescence, and you'll see that the kidney starts turning green, and that means there's blood flow. The bottom of the kidney where the tumor is remains gray, and there is no blood flow there. And so you see that the majority of the kidney continues to remain perfused or continues to have a blood supply, whereas the tumor doesn't. So we can do this operation, and we're cutting the tumor out here, while the remainder of the kidney stays with blood flow. And so again, we have what is essentially zero ischemia time on the rest of this kidney. It remains safe and it's not going to be harmed. And we can clearly cut out this tumor, and comparatively it's very little blood loss. I mean, this is a magnified view, but you're really talking a teaspoon worth. And here we're suturing the kidney back up. I'm just going to skip forward a little bit, putting the stitches in, putting some clips on so that the stitches hold, and this, for you golfers out there, this divot is closed off.
The clamp is removed, and
the clamp's taken off, and you see the final, the final product of the kidney. So, to answer the question, have we improved the patient outcome? And the answer is yes. We've significantly decreased this ischemia time and operating time. The average ischemia time being 14 minutes, and that's under half of that 30-minute mark that we want to achieve. But even more importantly is that we have these selective clamping techniques where we can essentially attain zero ischemia time. The blood loss remains low, on average 121 cc's, which is really a few tablespoons worth of blood. And the hospital stay, about 80% of the patients are home on the first day after surgery, excuse me here, and 95% are home by the second day. And then, of course, and most importantly, we want to keep a low complication rate. And that remains around 2.5%. So 97.5% of patients who are having this operation, this technique, really are not experiencing a complication. So we're getting there. And, I think there's more to come. But that's my overview of the technique. So I'm going to stop here. Let's see. How do I get back on?
That was great. That was great. Thank you so much. That was very enlightening. So tell us, I know you mentioned kidney cancer and robotic. Now, do you feel like robotic surgery, I know you kind of mentioned this before, it gives us better outcomes when it comes to the surgeries?
Yeah, I think when you measure outcomes in kidney cancer, you're talking about a couple of things. You want to completely remove a tumor, because this is cancer, obviously, but you also want to try to save as much normal kidney as possible. So the success is measured by, can you do a partial nephrectomy, and can you even do it in challenging and complex settings, like some of the examples I showed you. And if you can do that, and again, it's not necessarily if you have to do a robot or you have to do it open or laparoscopic. There are many ways to do it. But first and foremost, you want to do a partial if you can. But then secondly, you want to minimize that ischemia time. And that's where the robotic platform really has shined. Because we're able to reconstruct the kidney. You guys do reconstructive surgery, and you know that that's really the benefit of it. And this is one of those operations where we really do see that benefit. And then, of course, it's the recovery time. The recovery time of anything laparoscopic or minimally invasive will be better than a flank incision, which kind of goes to the side and the ribs.
So I know there's like some genetic tests you can get done for prostate cancer, breast cancer, colon cancer. I think Genomic Health has some testing, and it's great for those diseases that I mentioned. Is there anything out there for kidney cancer?
There is genetic markers for kidney cancer, but it's not exactly what we're talking about, like the Genomic Health product for prostate cancer. The Oncotype DX, which is for prostate cancer, is actually sampling the cancer cells from a biopsy and determining the aggressiveness of that cancer. And that is to determine if you're going to do a surgery or radiation or something like that, an intervention, versus watching that type of cancer. Here we're not exactly doing that. For the most part, you can watch some kidney tumors and do what we call active surveillance, just like prostate cancer. And then you treat other ones, and it's typically based on size, right? So if it's very small and it doesn't grow very fast, those are our parameters to maybe watch a tumor like that. But there's no real risk stratification test right now for kidney cancer. If you take a tumor out, you can do a certain genetic analysis and see certain factors that, pretend a more aggressive tumor, but that's after treatment.
Dr. Dunning,
I'm losing. You there? I feel like I'm on CNN. I'm not getting a connection. Hello? You guys there? Taking a nap? Let's see if I can find you. Can't find you. You there? Hey guys, you there? Hey guys. I lost you.